Okay, so let's move on. The next thing now is I've gone ahead and I've done a virtual wax up, or the laboratory has. They've created a surgical plan. I've validated it and said, yes, I like that plan, or make these changes for me. Now they can make the other things that I request for them. So, well, what other types of devices can we make now? Well, surgical guides, obviously, provisional restorations, custom healing abutments, custom abutments, whatever it is that you elect that's appropriate for that particular surgery. So let's take a look. Here's Tidra, right? There's area number 5. By the way, I don't know if any of you noticed, but you can see she has a deficiency in the buccal plate, right? Even with the deficiency on the buccal plate, you see with the soft tissue concavity, she has adequate bone. And then the question is, do you want to surgically correct that, and or not at the time of surgery? But again, with the digital intraoral scan, it's obvious for me, so within the treatment plan, I can make that, that decision. So number 1, a surgical guide for a fully guided surgical procedure is going to be made and is designed directly on that model. I have to send nothing else for that patient. So I don't have to take study casts with conventional material. I don't have to send them convention to the laboratory. I don't have to have them do a conventional wax up, send it back, verify it, validate it, take a CT with a barium template or any of those things. At the time of consultation, I get all the additional data, CAT scan as well as intraoral surface scan in about 3, 4, 5 minutes of extra time or additional time. And I don't even do it. My staff goes ahead and does that for me. Okay, so there it is, a surgical guide that's been designed on the same data set. Next, I want to go ahead and make my custom components. And we're going to go ahead and make a provisional, right? Design a provisional. So what do we do? What the laboratory will do is they can now take that same implant position, import it into software that does prosthesis design. So there's the implant as if you took an impression after the surgery was done. Also is the diagnostic wax up. They select the component that they want to go ahead and utilize. So we're going to do this as a screw-retained restoration. And the provisional component, that screw-retained titanium cylinder, comes from the libraries, right, that Paltop has embedded into the planning software. So within the planning software systems of 3Shape, the major one used in the United States, which would be 3Shape or Exocad or Dental Wings, are these libraries. And so the complete design, right, for the provisional restoration, including the selection of the exact component, okay, is done at this point. All I've done is seen that patient for an initial consultation of 30 minutes, and all this is being done behind the scenes. When this is being designed, we can look at everything. We can look at not only the implant position that's been imported, because that's where the implant's going to go, the design of the provisional to support the soft tissue, and to a certain extent go ahead, fill out some of that soft tissue concavity, but also design it that if it's going to be an immediate provisional, right, we have occlusal relief from that area. See, I want to do as little as possible when I actually treat the patient, right? I want it to be easier for me. I want it to be easier for the patient, right? That's my most expensive time. Right? So I want the laboratory to use its tools to create efficiencies for me. Also in this is the recognition that even if we're doing a guided surgical procedure, sometimes the implant may not be 100% in the exact precise position. If there's a variation of, a fraction of a millimeter or 1 degree of angulation, I don't want to fight with that provisional. See, for me, the most frustrating point and the biggest waste of time, when you do restorative dentistry of any type, right, is when you get a provisional restoration from the laboratory and you're fighting with it, right, for 5 minutes or 10 minutes or 15 minutes or 20 minutes, depending on how big the case is, to get it to fit. That any happen to anybody? So I don't want to do that, right? I want this to be simple and easy. So built into the libraries by design, okay? Because again, what we've done at Paltop is we've designed this for easy usage by the dentist. Built into the library of the provisional component, because it's understood the provisional component needs some leeway, is a spacer. So if you look at the component inside the provisional, I'm going to go ahead and point it out to you. Right there, right? Okay, see here you see the provisional component. Here you see it occlusal. You'll see this space. There's space. Space is built in, so when the implant is placed in that position, the provisional is just going to slide into place. I'd rather spend an extra 3, 4, 5 minutes putting in some, acrylic or a little more acrylic than spend 10 minutes or 15 minutes trying to get something to fit. Okay, so here's the workflow, right? Implant position's been imported. Provisional's been designed. provisional component's been selected, right? And it's all going to work. Right? And there's our provisional. So these are the things that I'm going to go ahead and I'm going to get back from the laboratory.